10 lah kan? Ke apa? 9? 10 kan? So rasanya boleh start. Kita akan stop after every 4 presentation kita akan stop for rest. Untuk rest lah. Okay, so siapa nak start tu? Hopefully by within 2 hours. Okay, Farah. Okay, good.
Doktor,
So,
kejap doktor, tengah bertekan slide. Sekejap. Tengah nak share slide.
Okay. So hopefully in 2 hours kita akan complete the class lah. Kita akan finish the class. Maximum.
Kita ada 5 prosedur tu.
Oh 5 je?
5.
Oh, bukan 10?
Bukan. Sebab ada 2 session.
Oh ya ke? Lagi satu session dengan siapa? Dengan orang lain lah?
Dengan siapa?
Dengan doktor juga.
Dengan
doktor juga.
Okay lah. Tak apalah macam tu. Bagus. 5. Okay. Unless kalau you guys nak finish the whole 10 hari ni, tak apalah. Tapi 5 dulu lah, 5 dulu. Okay, good. So once you're ready, you boleh start terus ya.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Farah Majaha and I will talk about venipuncture. Okay, next. Next, okay. So before we start the procedure, first of all, we need to wash or sanitize our hand by applying the 7 steps of hand rub or hand wash as part of the infection prevention and control practice. And then introduce yourself to the parent and the patient. Then identify the patient by seeing the wrist or foot bend if attached to the patient, or ask the parents for the child name and date of birth. Then explain to the parents about the procedure that we want to do and get the consent. So next. After that, gather all the equipments that we want to use, such as tourniquet, gauze, blood collection device, sample tubes, and alcohol swab, and also plaster. So next. So usually in pediatric patient, we use the 22 to 23 gauge needle, so the yellow and the blue color, or we also can use the right side picture, which is the butterfly needle, because the advantage of the butterfly needle is that it allows good flexibility if the child is struggling or twisting the arm during the blood taking, and avoid using too small gauge, such as 25 gauge, as it can increase risk of hemolysis of the blood samples. And then when we choose the syringe with volume 1 to 5 milliliter and gently pull the syringe. Because why? Because the vacuum that produced by drawing using a larger syringe will often collapse the vein and also increase a risk of blood hemolysis. Next. Choosing the correct vein is important. When choose the vein, try to begin with the most distal aspect of the vein, because it allows for further attempt above the side of the vein if the first attempt is failed. And also important in pediatrics, what I read is that we can maximum 2 attempt to do venipuncture. If we cannot, then ask for superior or more superior person lah. And then we can use the median cubital vein, you can see in the diagram, as it easily palpable and have well supported subcutaneous tissue. It means that they will prevent the vein from rolling under the needles, prevent the gerak-gerak. But the disadvantage is that it near to brachial artery and the radial nerve, so we need to be precaution. And then we can also use the cephalic and basilic vein, which is much larger than the medial cubital vein, but we usually do not use it because it has not well supported subcutaneous tissue. So it means that the vein can roll from the needle. And also the brachial artery are much more closer to this vein. And also the median nerve are close to the basic vein, and the radial nerve is close to the cephalic vein. Therefore, it has higher risk to potentially damage the nerve or the artery, and it is usually more painful. And then we can also use the metacarpal veins. It is the first choice in neonate and infant under 2 years, as other vein may not be accessed due to the high load of the subcutaneous fat, so macam tak nampak. But it only is suitable for small blood collection system like the 20T gauge butterfly needle. So next. Okay, this is the summary. Next. So after choosing the correct vein, then immobilize the baby of the child as the diagram shown, and then put the tourniquet on the patient about 2 finger width above the venipuncture site. This is to allow the slowing of the venous return and allow more blood into the area. As a result, blood back up in the vein, enlarging them so that they are easier to see, and also distending the vein walls so that it's become thinner and easier to pierce with the needle. But do not put it too tight as it can prevent arterial blood flow, thus difficult for us to obtain the blood. And then important to put the non-sterile glove to protect ourselves from bloodborne pathogen exposure, and disinfect the site with antiseptic which contains 70% alcohol for a minimum of 30 seconds and allow it to dry. So this is to avoid contaminating the specimen or prevent the infection to the patient with the skin surface bacteria. And then use the thumb to draw the skin. This is to prevent the vein from rolling from the needles. And then you can read it macam biasa. Okay, next. Next. Okay, and then to complete the procedure, discard the needle into the sharp bin to avoid needle pre-injury, and thanks the patient and fill in the blood bottle labels. Next. So there are many types of blood tube device collection. We can see on the left side we have the plain tube on the which doesn't contain any preservative, and then the yellow tube which contain true preservative such as the silica to activate the clotting and cause blood cells to come together. And also we have the gel that act as serum separator that form the layer between the blood cells and the plasma so that the sample can be easily centrifuged. So this usually, the yellow tube usually require in tests that require serum for analysis such as BUS, CRP, LFT, lipid profile, and hormone status, hormone level. And then the green tube, it contain preservatives such as lithium heparin to prevent the blood from coagulate, and usually used for the ammonia and chromosomal studies. And then the purple tube, which is more commonly used for, it contains preservatives such as potassium EDTA, which this EDTA acts as a potent anticoagulant by binding to the calcium in the blood. For it commonly used for hematological tests such as the FBC, FVP, SR, HbA1c, and GSH, GSM. But sometimes the GSH and GSM use the pink bottle. Then we have the blue cap, which have the sodium citrate. Sodium citrate act as reversible anticoagulant which bind to the calcium ion and disrupt the clotting cascade. So usually used for the tests that involve in clotting system, such as PT and APTT. And then we have the gray tube, which contain the sodium chloride. So this sodium chloride acts as anti-glycolytic, so that no further glucose breakdown occur in the sample. And also it contains potassium oxalate as act as an anticoagulant, so it used for glucose test, glucose function test. So next, so these are the recommended order of draw, so that to avoid cross contamination of additives between the tube. So we start with sterile blood, and then sodium citrate, PTFDT too, and then the pale tube or the yellow tube. Then we lithium heparin and potassium ETA, and then lastly sodium chloride and potassium oxalate. So that's all from me.
Okay, thank you, Farha. Thank you, Farha. So any questions from the floor? Anyone got any questions to ask? Okay, no. So basically in pediatric, most of the time we use the veins at the bottom of your hand rather than the antecubital fossa. Okay, because you correctly mentioned there's a lot of important structure at the antecubital fossa, veins, arteries, and also especially arteries, because they are quite superficial in pediatric. Okay, and also the nerves. And then besides that, we usually use sterile gloves rather than non-sterile gloves. I'm not sure why. Practically non-sterile gloves is better, but in pediatric most of the time we use sterile gloves. Okay, if you are taking blood, okay, if you are doing venipuncture, you will have to put tourniquet on top of the venipuncture kan, of the site kan. Then where do you have to squeeze? Remember in pediatric we do squeeze the hand. In adult we don't squeeze, because in adult the vein is large, and also venous return is, there's a lot of blood lah in the vein. But in pediatric we do squeeze the hand or the foot if you are taking blood from the foot. So where do you squeeze? Is it proximal to the injection site or distal to the injection site? Anyone? Have you seen we take blood from pediatric? No. So any guess? Where do you pump? It's not squeeze lah. It's a squeeze, but it's a matter of pumping lah. Where do you pump the blood? Distally, at the distal to your injection site or proximal to your injection site? Because this is quite important. Because in practical, a lot of people they squeeze at the wrong side, so they won't get blood.
At the distal,
Why?
because venous return go up, and then the arterial supply is actually somewhat impeded by the tourniquet.
Okay. Actually, we tourniquet to prevent the venous return. Kan? Because the blood flows is actually from distal to the cardiac kan, to proximal kan. It flows from the distal to cardiac. That is the venous return. So the role of tourniquet, that's why we put the tourniquet proximal to the injection site, so that the blood will pull distal to the tourniquet kan. So it will pull dekat area of the injection lah. Okay. And then we squeeze at the distal. Okay, to encourage, we are squeezing to encourage venous return. Okay, the arterial punya flow tu we are not interrupting it, because the tourniquet should not be too tight to the extent that it will disrupt the flow of artery. So the artery, the blood flow remains to the distal part, but we obstruct the venous return, and then we encourage venous return by squeezing kan. Because you understand the vein they've got valve kan. There's a valve inside the vein to prevent backflow. Tapi the vein has no, it's a low pressure system. So it need the muscle contraction will actually encourage venous flow. That's why kalau you ada prolonged immobilization, you dapat DVT kan, deep vein thrombosis, because there's a stasis. Okay, apa nama triad tu? Siapa tahu? The triad that pathophysiology. Virchow triad kan. So one of it is stasis kan. So by squeezing, you are actually pumping blood. Okay, next. Any more questions? Tak ada eh? Remember, in pediatric, we usually use drop method rather than we aspirate, because the vein is very small, it's collapsible. So if we aspirate, it will collapse the vein. So we usually use drop method. We collect the blood into the tube by dropping the blood directly into the tube. And the video, the image that you showed just now is using vacutainer. I'm not sure we are using vacutainer or not here in this hospital, but I don't think we use vacutainer. Vacutainer is a vacuum system. So you actually, the blood will go straight into the bottle, into the tubes. But in our setting, because we use most of the time in Malaysia, we use drop method. We don't have vacutainer, so we just use the simple, just use needle and then drop the blood into the tubes. Okay. Next.
Do you guys see the slide?
Yes.
Okay. Next, I'll be presenting regarding the IV cannulation. Before that, I would like to apologize because the pictures in this IV cannulation is actually the elderly, not showing the pediatrics. Okay. When we talk about the IV cannulation, actually IV cannulation is actually a technique in which the cannula is in place inside a vein to provide the venous access. And before we further performing the IV cannulation, we first need to know the indication and contraindication of IV cannulation, which the indication for IV cannulation would be the blood sampling, administer the fluid, medication, chemotherapeutic, and many others. Meanwhile, for the contraindication would be the coagulopathy. As we know that coagulopathy means that the person is tendency to bleeding, but it is rare to occur in IV cannulation because the IV cannulation, the site for IV cannulation would be easily to compress. It is a compressible site. Second would be the atrial AV fistula, which means that there is connection between the artery and also the vein. Where what we afraid more is actually we incidentally injured the artery, where it can cause like something like aneurysm, and also if we sensitize the artery, we actually can cause the artery to vasospasm, therefore causing the blood supply to the area would be reduced, which can also cause gangrene. Next would be the local infection. When there is local infection, we may introduce the microbes into the blood. And the next one would be the burn patient, in which in burn patient they lost their primary skin protection. And in thrombophlebitis, where we can see from outside there is redness, it is inflamed, and then it is painful. Where if we do the IV cannulation, where the cannula can irritate the vein, causing the vein to be more inflamed. Therefore, we aggravate the thrombophlebitis. Actually, IV cannulation, there is no absolute contraindication, but there are the relative contraindication that I have told, where relative contraindication means that we need a extra precaution to do the IV cannulation. Okay, next, the equipment that we need to prepare would be those that you see in this slide. But what I want to stress out is about the cannula, where already said by our presenter Farha, in which we have this specific cannula for the usage in the pediatrics. And next, the first we enter the steps for the IV cannulation, where the most crucial things in the IV cannulation and other procedure also would be putting on the glove, which we maintain the which concern regarding the hygiene and also our protection itself. And then second would be we preparing the saline flush, where the saline flush is actually the mixture of the salt and water, in which it can help prevent the IV catheter from becoming blocked and help remove the any medication that may be left at the catheter site. Okay, next would be the position the patient's arm, where it must be comfortable for the patient. As we know, it must be difficult for pediatric patient. In some patient, they need kind of two person in order to hold their hand. And next would be inspection for the suitable vein, where the site for the vein would be the site of least restrictive, which they commonly do would be at the dorsum of the hand. And it is rarely done, should be avoid done at the elbow and the wrist joint because there is tendency for dislodgement. And next would be we must apply the tourniquet, which about approximately 4 to 5 finger width above the planned cannulation site, where it should be pulled tight enough to cause the engorgement of the lower capillary and vein, where we occlude the venous retain, causing the vein to engorge. But as we know, as Dr. said earlier, the vein in children would be much more difficult as it is much more smaller than in adult. And then after we apply the tourniquet, we must palpate the vein, that suitable vein for the IV cannulation done. Okay. And then after we actually palpate the vein is actually kind of methods for vein dilatation. There are several methods for vein dilatation. Therefore, easier for us to do the IV cannulation. Which first would be we ask the patient to do to close open their face. Second would be we place the the hand below the level of the heart to help engorge the vein and increase visibility after putting on the tourniquet. Next would be gently tapping the area of the vein, where it can cause release of histamine beneath the skin and causing the vasodilatation. And another one would be apply warm to area about 5 to 10 minutes beforehand to dilate the vein. Next, we must clean the site by alcohol for 30 seconds and allow for dry for 30 seconds. And after we clean the site with the alcohol swab for 30 seconds, we should not touch it afterward as it may be contaminated unless we wear the glove. And next one, we prepare the cannula by opening the cannula wing if present and unscrew the cap at the back of the cannula. Next, we anchor we do the vein stabilization with our non-dominant hand by stretching the skin distally to the vein by gently pulling the skin in a downward motion, because this method can maintain the vein in stable position and reduce the tendency to roll. Apart from and then added with ensure the bevel in the pointing upward. And then we insert the cannula about 10 to 30 degree with bevel facing upward, as I said before. And then we observe for the flashback of the blood into the cannula chamber, which confirm that the needle has punctured the vein. But if the blood is the flashback is stopped, it may be the cannula has punctured the posterior wall of the vein, or the patient is extremely hypotensive. And then if the swelling develop, we must withdraw the device, release the tourniquet and apply the pressure for 5 minutes for the hematoma, prevent the hematoma. And then we partially withdraw the introducer needle and then advance the cannula into the vein. And then at this moment, we must release the tourniquet to ensure that when we proceed to removing the stylet, less blood will be oozing out from the cannula. And then before we remove the introducer needle, we may apply the pressure to the proximal vein to the tip of the cannula to reduce the bleeding. And then we attach the extension side, and do the and flush with the saline. As we know, saline is to make sure that there is patency of the flow. And then we immediately dispose of the sharp into the sharp vein. Next, we secure the cannula wing with some of the adhesive tape and add it with the details of the patient, because we know that the IV cannula should actually replace on every 3 days, because to reduce the tendency for the phlebitis to occur. And then in terms of the complication, it can be divided into local and systemic complication, where the local complication includes the damage to the artery or nerve, hematoma, bleeding at site of the incision, extravasation. Extravasation means that when we puncture the posterior wall of the vein, when we insert the medication fluid, it came out to the surrounding tissue of the vessel. And then the phlebitis, where it is due to irritation by the cannula towards the vein, causing the inflammation to occur. And then the systemic would be the vasovagal syncope. That's all for me.
Okay, good. Vasovagal syncope. Okay, any questions? Any questions, guys?
No.
Okay, basically quite straightforward. Any of you have seen IV cannulation done? Have you?
Yes, but not in pediatric patient.
Okay, great. So it's similar to pediatrics. The method are similar. The complications also similar. So in general, the principle is do no harm. So you have to do all the measures to prevent complication, especially in IV cannulation. You have to prevent thrombosis, thrombophlebitis, infection, bleeding, and also wrong puncture lah. Wrong puncture means you may actually puncture the artery. And then another thing that is very important that is not addressed in this presentation is actually pain management. Okay, do no harm. So cause the least pain possible. Okay, so what sort of painkiller can we give in pediatric for invasive procedure? For like mildly invasive procedure like this, what sort of analgesia can we offer? Anyone? Definitely in adult we don't give analgesia lah kan. So, kita ni kan cruel to adult. Tapi in pediatric kita tak boleh macam tu. So apa ya Zaid? Any suggestion?
Lidocaine.
Lidocaine good. What sort of lidocaine we can offer? Local anesthetic kan? What sort of local anesthetic yang kita boleh offer? Siapa yang ada darah kat sini?
Sorry.
Oh, so kalau orang ambil darah awak kan, demam darah kan? Selalu awak bagi, will you ask for local anesthetic ke atau you just you bagi lah?
Saya akan bagi.
So sakit tak bagi local anesthetic tu?
Sakit sikit je.
Ya, awak pernah ke? Awak pernah demam darah tanpa local anesthetic tak?
Tak pernah.
So mana awak tahu?
tak berani.
So actually kan, sama je sakit. Frankly speaking lah, you ambil LA atau you tak ambil LA sama je. Because the LA to itself is very painful tau. Because bagi LA, siapa yang kena injured kat sini? Terpijak pisau ke, pijak kaca ke, kena cocok ATT, pernah ke? Sakit kan? So because IM injection is very painful. IM subcutaneous, especially IM is very painful. So if you give subcutaneous injection, LA, and then you buat IV cannula, you insert IV cannula, chances are yang LA tu is more painful daripada ni. And then most of the time you will have like 2-3 attempts before you get successful IV access kan. So takkan you nak bagi LA setiap kali cocok. Okay kan. So LA is good but kena ada through other method lah, bukannya through injection. What other method we can apply LA?
Topical.
Topical good. Spray cream kan. Kita ada spray lah. Usually kita ada got amla lah. We call it amla spray. Amla ni is actually lidocaine ke? I rasa lidocaine. Lidocaine ke bupain macam tu lah. So just apply topically. Wait for like 5 minutes. Then only you inject. And then kalau baby, we can offer something else. Kalau baby apa yang kita boleh offer? Especially neonates lah. What sort of analgesia we can offer? Siapa nak tengok baby kena cocok? Tak naik. Actually we can offer things like dextrose. Bagi minum je. Bagi puting kan. Sometimes kita bagi puting, letak puting tu letak dextrose dalam kapas. Tahu dextrose tak? Dextrose. 10% dextrose tu. Soak kapas dalam tu, soak cotton dalam tu, pun letak kat puting. And then suruh dihisap. Ataupun just kain soak dengan ni, ataupun syringe lah, syringe yang dextrose. So sambil cocok dia, sambil bagi dia minum lah. So it's calm down. They will calm down lah. It works. Okay. So analgesia is very important in pediatric ni. And then sometimes we may need to sedate them, especially some patient yang tak boleh cooperate lah. Those yang with syndromic ataupun yang ada learning disability ataupun bukan learning disability yang ada mental retardation ke, then we have to sedate them lah sometimes. Okay, next. Rasa okay cepat.
Assalamualaikum warahmatullahi wabarakatuh. So, present about central venous catheter. But before that, disclaimer, I actually study this topic in not pediatric setting. So, based on what I've go through, I didn't find any much difference in pediatric, but I think Dr. will add some more. Next. So this is our line initial. Then next. So definition: central venous catheter, also called central line, central venous line, central venous axial catheter. It's a large bore central venous catheter that is placed using Seldinger technique, unless in clinical scenario premenstrual technique placement, such as in emergency setting. So in certain setting. So the site most commonly the most common site is at the neck in internal jugular vein. Then also the other side is chest, pelvian, axillary, femoral vein, or peripherally inserted central catheter or PICC. Next. So this is the indication for central venous catheter. So first is the administration of medication that requires central access, such as this example of medication. And then for fluid balance and monitoring central venous pressure. And then thirdly is intravenous access in for long term, such as medication lah. And then hemodialysis. So we commonly saw patient in who undergo hemodialysis with central venous catheter. Basically, most commonly we can saw at the femoral or at the internal jugular vein. And then for emergency cases, such as administration of electrolyte. Next. So this is the contraindication. So not much different from the previous procedure, such as radiography, because patients tend to have bleeding and then local infection, and then we avoid an increase in raised ICP, intracranial pressure. So if this in this case of raised ICP, so we aim for the site that are further down from the cranial ICP, such as the femoral. And then for patient there is non-compliance. Next. So this is example of the equipment required. So this is basically what I find. So first we have the number one, the syringe with local NS. So such as the lidocaine just now. And then scalpel to make a small incision. Then we have gel for ultrasound. So basically this procedure is highly recommended to be done by ultrasound guided. And then introduce a needle. Then we have the guide wire, tissue dilator, central line catheter. So in this picture, central line catheter is one lumen. So most commonly we see is the 3 lumen. So there's 1 lumen, 2 lumen, 3 lumen, and 3 lumen. And then we have the surgical tract and additional fastener. So this is to secure the central line catheter at the side by suturing. And then lastly the dressing. Dressing is the last process where we just secure the catheter. Next. So for procedure, so pre-procedure we first must ask patient consent. So in pediatric setting we ask the parents and then position. We took example for most common at internal jugular vein. So basically patient is at the Trendelenburg 15 degrees, and then patient head, we commonly use the right internal jugular vein. So patient face will face to the right, and then we'll access through that. And then ultrasound basically to help in determining the anatomical site, to check for the vein, and then to differentiate between the vein and the artery. Because by using ultrasound, we can actually saw when we put the ultrasound probe and when we press, the vein will be compressed. You can see the vein is compressed. And then assistant is highly recommended for monitoring patient. Next. So this is the full procedure lah, but I will just give the summary how the procedure is done. Next. So the procedure is done by what we call as Seldinger Technique. So this technique is Seldinger is the name of the person doctor who create the procedure. So after the we have wear the glove and then have put all the apa ni site semua tu. And then firstly we will give the local anesthetic, and then after that we will introduce the this needle with syringe and then by using the ultrasound for guidance. Then when the needle is placed, has entered the internal vein, so there will be the blood coming out, flash of blood. So when this happens, the syringe will be removed, and then the guided wire will be inserted. So this guide wire acts like some track macam railway track kan untuk kita guide. So when the guide wire has been inserted like 10 cm, so this needle will be removed. So what left in the internal jugular vein and coming out from the patient skin is the guide wire. So at this point, a small incision will be done. Look at D. So a small incision at the side. Then next. So the small incision is to help in introducing the next step of using dilator. So dilator is then put inside the guide wire. So dilator. So dilator, the function is to create a track that is big enough for the central catheter then to be introduced. So the step to introduce dilator is by twisting. So we twist and then tekanlah masuk. Then after that, after the dilator have been introduced like 2 to 3 cm, so then the dilator will be removed. So at this stage, the final stage is to introduce the central catheter. So still when the central catheter have been put inside the patient internal jugular vein by ultrasound, so when it's placed there, so lastly the guide wire will be removed and then the catheter will be secure, will be secured and then will be covered. So next. So this post procedure. So the central line will be attached to pressure bag to monitor the patient central pressure, and then the blood sample blood will be taken for investigation. And then this the most important is to chest X-ray to confirm placement of the central catheter and then to check if there are any complication. So in this such an pneumothorax. So in this X-ray, we can this is the right placement of the central venous central catheter. So we can see that the central catheter is placed at the interjugular vein. So it is located at the junction between the superior vena cava and the atrium, right atrium. Next. So this is example of complication that may happen: hemothorax, hematoma, and inadvertent of artery puncture. So in this X-ray, you can see that is subclavian catheter. So we can see that there is here the pneumothorax because of the injury to the lung pleura. So we can see the area here at the That's all for me.
Okay. Good. Very good. So CVC. So basically CVC in adult and pediatric are the same lah. CVC we've got CVC is actually a central line. Central line is a line, is a big line that is inserted where the tip reside at the great vessels. So where the tip should reside at the great vessels. So if you are inserting central line at the lower limb, the tip should reside at least at the inferior vena cava. So it should enter the inferior vena cava. Kalau the upper limb should enter the right atrium, right atrium lah, at least sampai right atrium. Not too deep, tapi at least at the entry of right atrium. So you've got femoral line. In pediatric, most of the time we use femoral line because it's the easiest. And also we've got the IJC lah, internal jugular. So in general, we have to use the procedure is done under sedation, okay, under deep sedation. Patient should be deep sedated lah. And then you've got two types of central line. Okay, you've got the tunnel and non-tunnel catheter. Okay, tunnel catheter means you have to plate the tunnel. And it has to be done under OT lah, under surgery. So tunnel catheter like Hickman, like chemopod, Hickman, and then you also got permanent catheter kan. Permanent catheter it can be either at femoral ataupun kat IJC, but these are tunnel catheter. And there are also non-tunnel catheter macam femoral line, IJC, yang simple lah. And also lastly we also got PICC, peripherally inserted central catheter. These are actually central catheter that is inserted peripherally at the end, dekat distal, very small catheter, but it again is end up is the tip resides at the right atrium. Okay. And then what important about central catheter is the complication. There's a lot of complication in the use of central catheter. Things that you mentioned, pneumothorax, chylothorax. You can get thrombosis, catheter migration. There are times where catheter can actually dislodge. Just imagine the long catheter can actually migrate. Okay, and there's one special catheter only available in pediatric in neonates, which is the umbilical catheter. Okay, umbilical catheter is a central catheter as well. So only in neonates you've got umbilical catheter. And then again, the procedure is always it's a sterile procedure. It has to be septic, then in septic. It's a septic way lah. And then to cukup. Any other questions regarding this CVC? Okay, ideally it should be done under ultrasound guided. Okay, ultrasound guided. But most of the time in Malaysia we don't use ultrasound lah, especially for femoral line. We use blind. Tapi IJC memang biasanya guna ultrasound guided. Okay lah, next. And remember the technique is called Seldinger Technique. Okay, this is very important technique. This is to make sure you're going to insert the catheter in the correct vein. Okay, you cannot blindly puncture because you might end up in the artery. Okay, so next part culture.
Bismillahirrahmanirrahim. Can everyone hear me?
Yes.
I'm sorry because currently it's raining outside, so my internet line is a bit low. Okay. My name is Izzatun, and today I will discuss about the blood culture procedure. So blood culture is used to detect bacteremia in children and infants. So the validity of the result obtained is entirely dependent on the specimen collection. Any inaccuracies can lead to diagnostic and therapeutic difficulties. In blood culture also, there will be contaminations or false positive blood culture will lead to inappropriate treatment, increased hospital stays, and goals as well as increased hospital lab and pharmacy costs. That's why we have to learn this in order to we can prevent from doing any mistake. So next, so the indication for blood culture, like I said before, it should only be taken when there is a clinical reason to suspect a septicemia. And bear in mind that the blood culture should not be taken for routine assessment or for the investigations of a localized infection. So there are several clinical symptoms that may indicate sepsis, which we can perform blood culture. First, the temperature more than 38 or less than 36 degrees Celsius, presence of tachycardia, sustained hypotension, and tachypnea, chills or rigors, and then raised or very low white blood cell count, the presence of new signs of confusions or worsening signs of existing confusion, and lastly, unexplained risk CRP. Next. So, basically, when taking blood culture, we need two types of medium. First, aerobic, either it is aerobic or anaerobic blood culture medium. But however, this medium also, we have another medium, like different types of medium that contain different types of growth formulation to support the growth of other pathogens such as strep pneumoniae, Haemophilus influenza, and others. So next. Next. Oh, okay. For Arabic, for the Arabic bottle, okay, previous slide please. So how to identify this one is Arabic or anaerobic bottles? You look at the cap. Usually the Arabic blood culture bottles, the cap is blue, while the anaerobic it has purple cap. Next, please. All right. So these are the pathogens based on the classification, either it is aerobic, anaerobic, or facultative. So for the here usually in pediatrics, in pediatrics the anaerobic infection actually are unusual, and most anaerobic will go in aerobic culture bottle. So if you obtain in adequate volume of blood, so the blood should be put back into the aerobic bottle rather than splitting the volume of the blood into two. So these are the example aerobic such as Bacillus species for gram-positive and Pseudomonas aeruginosa for gram-negative. For the agent that require further discussion with microbiologists needs special preparation such as Cryptococcus uniformans, Legionella, Mycoplasma. Next. Okay. The weight for pediatric, the recommended blood volume should be based on the weight of the patient, and an aerobic bottle should be used unless there is sorry. So an aerobic bottle should be used unless an an aerobic infection is suspicious. So if you see from the table there, for the children less than 1 kilogram, so we withdraw 0.5 to 1 ml of blood, and just follow this guideline. So for 40 kilo or greater, so we took from two sides, side 1 and side 2, 20 ml respectively. Next. So the site collection usually we take from the peripheral. So but we have to consider additional blood culture if there is presence of lung sepsis or there is a difficulties in obtaining the peripheral access. Next. So here's other equipment. Okay, let us try to okay. Okay, what is one? Next. So the first one is dressing bag. Okay, second, we need sterile glove. Third, it is the butterfly needle. Fourth is we use 21G needle. Fifth, we use shrink. Six, Chlora prep swab. Seven, Chlora prep 3 ml applicator. Eight, it is anaerobic blood culture bottle. And 9 is the aerobic blood culture bottle. So this is the equipment that we are needed for blood culture procedure. So next, for the procedure, so first thing first, we have to review the physician orders for blood culture and determine if anaerobic culture are to be collected. There are several indications for anaerobic culture, such as the presence of intra-abdominal or pelvic infection, necrotizing enterocolitis in neonates. Second, there is mouth or neck infection, such as septic thrombophlebitis. Third, necrotizing soft tissue infection. Fourth, infected bite wounds. Fifth, immunosuppressed host. And then prolonged fever of unknown origin with negative aerobic culture. And last but not least, all children more than 40 kg. Next. Okay, second we have to identify the patient. This is important because if we fail to identify the patient, uh, it will lead to errors and recollections of the blood sample. And but what we have to do, we have to compare the name on the requisitions and the labels to the patient ID band. Third is explain the procedure to the patient and family. This is we want to evaluate whether the family is already understand with the procedure, and we at the same time we want to confirm concern for the procedure. This one also will help to reduce the anxiety about the current clinical situation which the patient is having. Next, uh, no. Or if we have to clean non-porous work surface with hospital-grade disinfectant wipe. This is just a routine infection control practices. This also will help to reduce the transmissions of microorganisms. Five is we perform hand hygiene, like what the previous presenter had discussed. Samely, this one help to reduce infection. Six, we prepare equipment using aseptic technique at the bedside of the patient. And next, we remove the protective cover on the blood culture collection bottle. And also we scrub the top of the culture bottle with with chlora prep for 30 to 16 seconds using good friction. This one, why we use it, we do this because we want to decrease the risk of blood culture contamination. And then we allow to dry for 1 minute. Next. And then we initiate the peripheral IV. And then once the PIV institute is start, and then we clamp the PIV extension tubing. And then we remove the tip of the PIV extension. Next, we attach the sterile syringe, like in the picture. Attach the sterile syringe to PIV extension tubing, and then unclamp the catheter and withdraw appropriate amount of blood required by pulling back on the plunger of the syringe gently. This one, we have to ensure the appropriate amount of blood volume because appropriate blood volume will result in accurate blood culture test. Low volume of blood usually will lead to false negative result. Next, okay, next slide. Then we clamp the extension tube. Okay, remove the string from the needleless connector and attach the blood transfer percutaneous device. Then we immediately transfer the blood into sterile sample syringe for appropriate blood culture collection bottles using the blood transfer percutaneous device. Okay, once in the tube, once the blood is already in the tube, uh, we have to invert it to ensure the blood cells will mix with the content in the tubes, and then make sure do not shake the tube because it will cause the cell inside lysis. And then if we need further blood sampling requirement, and then we use new sterile sample syringe. If no further blood sample required, then we just use sterile pre-filled normal saline syringe and then unclamp the extension tubing, and then with a thumb on the plunger of the syringe, give 2 or 3 quick pushes of the normal saline into the tubing. Then with a continuous fast motion, flush the rest of the normal saline required into the line. After that, we can attach the needleless connector to the end of the IV extension tubing and continue with IV comments, therapy infusion for order or saline dot IV for order. And we have to label the blood culture collection. So this blood culture collection contain of the label must include the MRN, the first and the last name, the date of birth, the data and time sample drawn, and on the blood culture bottle must indicate which site, either it is from purpose site or central site, and also the volume of blood placed into the bottle. And then lastly, we arrange for blood sample to be transported to the lab. So make sure that we place the specimen into Ziploc tight bag or sealed bag. Okay, I think that's all.
Okay, good. Okay, so basically, blood culture is straightforward. Okay, it's a very important procedure. In pediatric, we usually just take one sample. We don't take both anaerobes and aerobic and anaerobic. Just one bottle. We got like special bottle lah for pediatric. I think it's pink color rather than blue or red. There are also special bottle for fungal because fungal you need to culture for longer period. And then, okay, I've got one question. Okay, what is the antiseptic of choice in pediatric? Does it really matter, or is it what type of antiseptic you guys know?
Alcohol,
Okay, alcohol,
chlorhexidine,
chlorhexidine lagi. Apa yang commonly used, especially in adult, especially for procedure. I think in blood culture in adult also use another solution. Povidone kan, usually they use povidone iodine. Povidone iodine is commonly used in adult. So in pediatric, in general, we don't use povidone for younger children. It's contraindicated in less than 2 years old. And again, chlorhexidine also is not licensed for less than 2 years old because of risk of burn and chemical burn. However, in pediatric, most of them use chlorhexidine and alcohol. Even though chlorhexidine is actually not licensed, but it's not contraindicated. Tapi iodine memang definitely is a no-no for pediatric, especially for neonates. Because the risk of systemic absorption that can cause hypothyroid thyroid dysfunction. So remember, thyroid povidone iodine cannot be used in neonates, especially prem neonates, and also young pediatric patient, usually use chlorhexidine, but different concentration. Okay. Higher concentration will be used for sterile procedure macam blood culture. Tapi for non-sterile aseptic procedure, kita guna lower concentration. Maybe like 0.5% or in alcohol lah. Most of them is in alcohol atau it can be also in aqueous. Okay, tapi most of them in alcohol lah. For blood culture, usually we use 1.4 to 2% chlorhexidine. And then each of these antiseptic kan, dia ada dia punya benefit, dia ada dia punya pros and cons, and the coverage is different. Okay, for example, macam chlorhexidine is not very useful for fungal. Iodine is better for fungal lah. Macam tu lah, dia ada pros and cons lah. And then rasa tu cukup. Okay, can we have a rest for like 2 minutes? And nak pergi ambil something jap.
Okay.
Assalamualaikum. Okay, Syaifan nanti boleh start lah.
Assalamualaikum warahmatullahi wabarakatuh. Can you hear me?
Yes.
Okay. So I will continue the presentation on the nasogastric or orogastric tube insertion in pediatrics. Next. Next.
Siapa jaga slides?
Yeah. Very high good.
Doctor, Fatin said that there is a problem. Her laptop is loading.
Memang tak payah present lah, tak payah ni. Tak perlu slide.
Tak payah guna slide.
Tak payah, just present.
Okay. Next, as an introduction, can you hear me?
Yes.
Okay, as an introduction, nasogastric tube or orogastric tube is a hollow tube which is passed through the nostril or the mouth into the throat and then down into the stomach. As for the indication, the NG tube or orogastric tube is indicated is indicated for enteral feeding and also medication administration in premature baby and also in a child who has a poor oral intake secondary to depressed mental status or due to a poor pharyngeal muscle control such as in the cerebral palsy or in the neuromuscular disease, in patient with endotracheal intubation and also in patient with poor appetite. And then the next one is the indication for NG-tube is the evacuation of the stomach content, such as in the bowel obstruction. Next. So this is the contraindication of NG-tube. The absolute contraindication, the first one is in patient who has known or suspected for nasal, facial or basilar fracture. Because the NG tube insertion in this patient can aggravate the injury and also there is high risk for the tube to enter the cranial vault. The second absolute contraindication is the clinical disorder of the esophagus or stomach, such as in the esophageal atresia or in the severe esophageal stenosis, and also in the esophageal and or stomach perforation. The next one is the caution must be taken in patient who has esophageal or gastric varices, receiving anticoagulant therapy, or in patient with thrombocytopenia, specifically less than platelet count less than 50,000 per mil, because this patient has high risk for bleeding. Next. I will Before I proceed to the procedure, I will briefly explain on the anatomy involved in the NG tube insertion. But you cannot see the image, right? Okay. The NG tube insertion starts from the nares, which is the entry opening of the nasal sinus, and then 5 to 7 centimeter behind the nares is the nasopharynx. The nasopharynx is continuous with the oropharynx, and below the oropharynx is the laryngopharynx. So the pharynx starts from the base of the skull to the opening of the esophagus is about 12 to 14 centimeter. Next, the pharynx is continuous with the esophagus. Esophagus starts at the level of C6 at the upper esophageal structure, and then go down, go through the diaphragm at the level of T10, and then open into the stomach in the abdomen. The length of the esophagus in an adult is about 25 centimeter, and the length of the stomach is variable because the stomach is distensible. So in an empty stomach is about 25 centimeter. Therefore, in an adult is needed about 55 centimeter of NG tube to be inserted in an adult. However, in pediatric patient, this tract is much more shorter and variable according to the age. For example, esophagus during the birth is about 8 to 10 centimeter, while in patient with of 15 years old is about 19 centimeter. Therefore, after this, I will describe how to measure the NG tube needed to be inserted. Next. Okay. As for the procedure, is not very detailed. But first one is we prepare the equipment. These are the list of the equipment needed in the NG tube insertion. The first one is nasogastric tube. There are three types of nasogastric tube. The nasogastric sum tube, stylated or non-stylated feeding tube. As for the nasogastric sum tube, is only used for aspiration, not for feeding. For the stylated feeding tube is usually used for long-term feeding, while non-stylated tube is used for shorter term, shorter length and intermittent enteral feeding. Next one is the suction source lubricants to lubricate the tube, catheter tip string, suction connector, anti-reflux valve, tape, the pH paper to confirm the placement of the NG tube and clear adhesive dressing. So next, for the measurement of the NG tube, in order to find the correct length, is that we must measure from the nares or from the bridge of the nose to the ear loop, and then to the halfway between the xiphisternum and also umbilicus. Next slide. This is example how to measure the NG tube. Next. So and then the positioning for an awake and also alert patient, we must put them in semi-upright position so that they can sit up and swallow. However, in sedated patient, we must lie them down in semi-elevated bed and also head to the left, so that if this patient vomit, the vomiters will not he or she will not aspirate the vomiters. So next, we will lubricate and advance the tube. During the insertion of the tube, we must put the patient's chin near their chest so that the tube goes backward and downward. We don't want to the tube to go upward. And then if the patient is older enough, ask them to swallow and also sip the water because the swallowing can assist the insertion of the NG tube and also reduce the risk of the NG tube to enter the lung. Next. I will briefly explain before. I will explain on briefly explain on how the swallowing can prevent the misplacement of the NG tube. So, as we all know, the pharynx is divided into three divisions, which is the nasopharynx behind the nasal sinus, oropharynx behind the mouth, and also laryngopharynx below the oropharynx. And then the swallowing, the mechanism of swallowing, there is three: the oral phase, pharyngeal phase, and also esophageal phase. But I will only explain on the oral phase and also pharyngeal phase. As for the oral phase, the food or the water is propelled by the tongue into the oropharynx. Then the pharyngeal phase will be triggered or initiated. In the pharyngeal phase, the soft palate, as you can see in the third picture, the soft palate is raised so that the nasopharynx is blocked. This is to prevent the pressure from pushing the food into the nasopharynx. And then during the swallowing also, the oblique and also transverse arytenoid muscle brings together the arytenoid cartilage so that the glottis is closed. And at the same time, the arytenoid are tilted forward so that is being closed by the epiglottis. In a simple word, we can say that during the swallowing, the soft palate is raised so that it closes the nasopharynx, and at the same time the larynx rise up so that its opening is being closed by the epiglottis, so that the food will not enter the larynx and the food will pass into the esophagus. However, if the patient is talking or before, if the patient is talking, or crying during the swallowing or during the NG tube insertion, the tube can enter the larynx and also into the lung, because the act of talking and also crying will cause the larynx to be open. When the tube enter the larynx, there is a reflective cough is triggered in order to push out the foreign bodies from the lungs. So before slide previous. So, in the NG tube insertion, we must be aware if the patient is persistently coughing, choking, and also have trouble in breathing, because this could be the sign of the tube is in the trachea. So, when this happen, we must pull out the NG tube immediately. Get the patient to rest, and then we attempt to insert the NG tube. And then we advance the tube until the predetermined mark. Lastly, we will secure the tube usually at the side of the face with a tape, or most preferred is the transparent tape, because we can monitor the skin underneath the tape. Next. Okay, this is methods to confirm the placement of the NG tube. The first one is the air installation. Connect the shrink to the NG tube and instill about 5 to 10 milliliter of air into the stomach, and put the stethoscope over the stomach to hear the gushing of air. However, this method is not reliable in pediatric patient, because in a small children, we can still hear the gushing of air even the tube is in the lung. Okay, next we move on to the second method, which is the testing the pH of a gastric aspirate. If the gastric aspirate is 5 or less, it's confirmed the placement of the tube is in the stomach. However, if the pH is 6 and above, then the tube is not correctly placed in the stomach, or the patient has taken any medication that has adjust the pH of the stomach. So the last one is the abdominal X-ray. So abdominal X-ray can be used to demonstrate the nasogastric tube placement in the annex. In the abdominal X-ray, as you can see the above picture, this is the correct placement of the NG tube. So the NG tube must remain in the central or in the midline down to the level of the diaphragm, and we must clearly see the tip of the tube is below the diaphragm and also in the stomach. Next. Last one is the complication of the NG tube insertion. Can be divided into during the insertion and also during the use. As for the during insertion, as I have explained before, it can has high risk for malposition because the esophagus and also the larynx is close together. And then the next one is the esophageal or gastric perforation. This is a rare complication. However, it can occur especially in pre-existing esophageal disease, such as in unrecognized diverticulum of the esophagus. The last one is the vomiting and expression. This can occur because of the placement or because of the presence of the NG tube itself. The lower esophageal sphincter is not fully contract and can cause the gastric content to reflux. And then the next one is the during the use. the patient can have sinusitis, especially in a long-term usage, because the tube can damage the ciliary epithelium of the sinus and cause infection. Second one is the unplanned dislodge and migration. This can occur. Therefore, we must always monitor the predetermined mark on the tube. The last one is the blockage. Can occur due to the clogging of the food or any other particle. Therefore, every time we must flush the tube after the feeding or after the administration of medication. Okay, that's all from me.
Okay.
Tengok. Okay, sorry. Okay, thank you. So it's very good presentation. So rice tube or orogastric and nasogastric tube is a very important procedure in pediatric, especially in neonates. Okay, where we use rice tube as a mode of feeding lah. And then we also use it to deliver medication in intubated patient for medication, and so to prevent in patient with low GCS kan, to prevent aspiration. So any questions on ni? So orogastric? Tak ada kan? Okay, so just now who presented is Farha. So the first one is Farha kan? Farha lagi?
Fatin Hanani lepas tu.
Fatin lepas tu?
Nik Zaid.
Zaid, okay.
Izzatun. Nafsia.
Izzatun.
Lepas tu Sharifah Nur Haiti.
Sharifah. Okay lah. I give you guys 8 lah, 8/10. Actually everyone I give 8 lah. Unless kalau very outstanding then I bring up the marks. If not then I'll go low. But usually the baseline is always 8. Okay, any more questions?
Doctor, I want to ask, in the NG tube, macam mana? Kalau kalau adult patient kan kita kena pastikan yang NG tube tu 10 cm below the lower esophagus sphincter tu kan. Kalau pediatrics kena panjang tu juga ke tak payah?
Oh, I'm not sure about that. Tapi pediatric, as long as the tip is correctly located, then it's okay. So in pediatric, the main method is actually by X-ray lah. All rice tube, all oral and nasogastric tube inserted need abdominal X-ray to confirm position. Okay, before it can be used. Usually we use it before X-ray, but ideally have to do X-ray before using. Okay. Tapi in terms of berapa cm tu, yang tu tak sure lah. Rasa tak ada. There's no hard rule. Tu apa ya? And then the size, generally speaking, we've got 2 size yang kita selalu guna, 16 and 18. The color lah, based on the color. 16 and 18. It depends lah. These are the 2 size. Okay, ada yang short, ada yang long. It depends on the size of the baby lah. But make sure you measure it first. Okay, measure it first. And then besides that, what you can do is, while you can actually ask the child to drink water while inserting the rice tube. Because when you swallow, it will actually helps with the insertion of the tube. Okay, because when you swallow, it will, your glottis will block your your epiglottis will block your glottis kan. So it prevent aspiration lah. Your aretina, aretina tu, dia akan block dia punya glottis. So it prevent aspiration. Okay? Any questions? Okay, kalau tak ada, okay lah. Kita tangguh dulu lah. Dan kita speak up orang. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doktor.
Okay, Doktor.